Good morning, everyone. My name is Braveen. I'm one of the chief residents, and I have the distinct honor to introduce Dr. Rachel Berger today for Grand Rounds. Dr. Berger is a professor of pediatrics at the University of Pittsburgh and chief of the Division of Child Advocacy at UPMC Children's Hospital of Pittsburgh. She attended medical school at Columbia University, completed her pediatric internship residency and a fellowship in general academic pediatrics at UPMC Children's Hospital of Pittsburgh, and received a Master's of Public Health at the University of Pittsburgh School of Public Health. In addition to evaluating children with concerns for abuse and neglect, she has spent over 20 years as a clinical researcher. Her research has focused on decreasing fatalities and near fatalities in young children by improving identification of suspected physical abuse using serum biomarkers, clinical decision rules, and the electronic health record, and by decreasing unsafe sleep in infants. Her research has been funded by the NIH, PCORI, the CDC, the Beckwith Institute, the Hillman Foundation, and others. She has co-authored over 100 peer-reviewed publications and book chapters, and recently became the first child abuse pediatrician to be elected to the American Society for Clinical Investigation. She was also the first woman to serve as the professional staff president for UPMC Children's Hospital of Pittsburgh, a role which she held from 2017 to 2019. She has also been involved with child abuse related policy and served on the Pennsylvania Task Force for Child Protection and as the research lead for the Federal Commission to eliminate child abuse and neglect fatalities during the Obama administration. She served as a senior policy fellow for the Casey Family Programs in 2019, during which time she took a six-month sabbatical. Dr. Berger's presentation today is breaking down silos, decreasing child maltreatment fatalities by improving collaboration between medical professionals and child protective services. Please join me in welcoming Dr. Rachel Berger.
Thank you, and good morning. I'm going to talk today about decreasing child maltreatment fatalities. Okay, apparently I can't forward this. All right, try again. I want to start with some acknowledgements because really none of this work could be done without these other people. So first, I want to thank Casey Family Programs, who funds the Senior Policy Fellow Program, which is a really unique fellowship in which professionals from fields related to but outside of child protection provide their expertise. So the year that I was a Senior Policy Fellow, which is 2019, the other fellows included 2 economists, an anthropologist, and myself. So people with expertise outside who then try to make a change within the field of child protection. So I want to thank all those people and others. And of course, Allegheny County Department of Human Services, and listed just some of the many people. And as I'm going to talk about, Allegheny County is really unique in many different ways, but one of the many, many counties I worked with during the Casey Family Program policy fellowship, which was during my sabbatical, Allegheny County was by far the most willing to start breaking down some of these silos. Obviously want to also acknowledge my colleagues. Without them, I clearly could not have taken a sabbatical, and I feel incredibly lucky to work with this group of people. And my research team, the strong and mighty, who have really helped with everything and could not do without them. And finally, Dr. Dermody, the Department of Pediatrics, for allowing me to take a sabbatical, which apparently had not been done for a clinical person in over 15 years. And so I said, I really appreciate their willingness to work with me to make this work.
Thank you so much, Dr. Berger. Are you able to try to share your screen one more time for us to see your slides?
Oh, darn. Okay, let me try again.
Mm-hmm. Yes, we can see them.
Okay, you can see them now?
Yes.
Looks good.
Okay, so I guess you missed the first view, but there we go. All right, well, can you see? We'll move on to the objectives. We're going to talk about child maltreatment fatalities in the United States, talk about communication between child protective services and medical professionals, talk about Senate Bill 27, which is a Pennsylvania law, and to learn about a new approach that we are looking at to enhance this communication. So just by way of background, in 2018, there were over 4 million referrals for suspected child abuse and neglect to child protective services around this country. 680,000 of those children were indicated as victims of abuse or neglect, which means that those children had injuries or incidents that met what the criteria was for that state law for child abuse or neglect. So this is a significant underestimate, but still it gives us some sense. It's a very big number. About 1,750 children died of abuse or neglect. And I always have to stop and think about that. That is an incredible number. Last year, about 200 children died of RSV, about 180 died of influenza. And at the same time, 1,750 children died from child abuse. 72% of these kids were under 3, and half of them were under 1 year of age. And the number of children who have died has actually increased over 10% over the past 5 years, which is obviously a really important and discouraging statistic. So in terms of child maltreatment by age, the younger you are, the more likely you are to be a victim. And as you see, there's a significant drop off after 1 year of age, but there's still a steady number of maltreatment victims over time. But if you look at the fatalities, clearly this is a much more significant difference, where under 1, we have a much larger rate of fatalities, which drops off fairly quickly and really almost is non-existent once you go past 4 years. There's a few, but very few. So the Commission to Eliminate Child Abuse and Neglect Fatalities was really the first effort of the federal government to try to address this really it's a devastating problem. And so this was established by the Protect Our Kids Act in 2012. It had bipartisan support and a unanimous vote in the Senate, which I think we almost never see now. And it was signed by Obama into law on January 14th. And this commission was designed to develop a national strategy and recommendations for reducing fatalities across our country. So I had the opportunity to serve as the research lead for this, meaning my role was to try to make sure that the commissioners develop their recommendation based on evidence. So interestingly, just about a year after this, and really when the commission just started working, the Miami Herald published a piece called Innocence Lost. As you see, this is March 2014. And it had photos of 477 children who were known to Child Protective Services in Florida who subsequently died. And the article starts with all of these color photos of the 477 children. The commentary that followed this, or one of the many commentaries, I think if you think about this and don't forget, I think the last sentence, then you will do well moving forward as you try to think about how we as physicians can improve this problem. I just want to read this. It said, "This was a mass killing, a massacre of babies. They were beaten, burned, choked, drowned, smothered, tortured, shot, hurled against bathroom walls. They were starved to death. Each individual killing could be blamed on the cruel or negligent or raging act of a particular parent or parent's lover. But in the aggregate, the 477 child deaths implicate other culprits. You and I, in our detached indifference, became accomplices in this carnage, along with the government agency we've so half-heartedly tasked with protecting Florida's children." And obviously this is not specific to Florida, but I think what our role and what I hope that you get out of this is that we can help this problem, that working with our government agencies is one way that we can help decrease these deaths. So CCAMP, so after 2 years after, CCAMP issued its final report to the president, March 18th, 2016, and this was called Within Our Reach. And I just want to go over, there were 5 significant findings, which tell you of all the 17 states we went to around the country, the hundreds and hundreds of people we listened to, there were 5 things that everybody could agree on were the most important conclusions of the task force as ways to decrease child fatality. 2 of these involved healthcare. One is involvement of healthcare and public health agencies and professionals is vital to the safety of children, and well-coordinated interagency efforts are essential. The second was importance of child protection services workers' access to real-time information about families, as we're going to talk about. A lot of that is medical or health information, cannot be overestimated. So I want to start talking a little bit more about fatalities and where our role may be. So about half of children who die are known to Child Protective Services, and some of them have been referred multiple times. When we look back, almost all of them should have been known, but our focus really has to be on those who are known. And we're going to focus today on the subset when the missed opportunities to protect children involved medical professionals. So what are those particular opportunities? So there's sometimes that physicians or medical professionals don't identify that there might be abuse. For example, the fact that a child comes in for wheezing and the weight has dropped from 50th to less than 1%, and someone doesn't look at the growth curve or they don't recognize it and the child goes back home. or the provider doesn't realize that there's a bruise on a 2-month-old, and that should prompt a child abuse evaluation. So that's about identification. The other potential is they don't properly evaluate the potential for physical abuse, for example, by doing a skeletal survey. And then another is that they simply don't report. These are all really important, but they're not the ones we're going to talk about today. And actually, these are the ones that most of my clinical research has focused on, but I said that's not our focus today. Our focus today is when their concern is reported, why might we not have been able to protect the child? And this is the idea that potentially the concern is not handed off in a way which allows Child Protective Services to make an accurate assessment. And of course, there's things further downstream like errors in decision-making where there might have also been something that could have been changed. And of course, many of these things often happen together. So many of you have seen this paradigm that we always talk about, that all of these parts of the puzzle need to work in order for children to be protected. And previously, most of what I've spoken about has been identification and evaluation. But today we're going to focus exclusively on this idea of mandated reporting and how to provide Child Protective Services with the information they need and work with them to make sure they can make accurate decisions. So this is a sad but not an atypical case, a 23-month-old reviewed by the County Fatality Review Team. The child died from an abusive abdominal injury and was found on autopsy to be severely malnourished. Child Protective Services actually knew about this child at 9 months of age when she was seen for a humerus fracture. The referral had been made to Child Protective Services, but no skeletal survey was done, and the referral said that the parent had fallen off the bed, and that's it. It didn't say why they were concerned or whether the bed fall was even consistent with a humerus fracture. Child Protective Services tried, but was unable to contact the mandated reporter. They unfounded the case, meaning they could not say this was child abuse, and they referred the parent for parenting classes. At 12 months of age, the PCP saw the child for bleeding from the ear and a bruise on the helix of the ear. The baby was diagnosed with otitis media, and it doesn't appear that the physician considered trauma as an etiology. And the provider also didn't notice that they had had no well child care since 2 months of age, and that the growth chart had shown a drop from 25th to under 5th percentile. It's unclear whether the child was undressed, so the weight may have been even lower than that. At 18 months of age, the child was seen in an urgent care center for a diaper rash, and there was a referral to the CPS for the diaper rash. Unclear why they were referring it. It didn't say what the concern was. And again, it doesn't seem that anyone noticed her weight. This referral was screened out, something that I'm going to talk about later. The next contact with the family was at the time of the fatality. So clearly there are lots of issues here. There are lots of different potential places where this child might have been protected. But the two we're going to focus on today is this idea of the handing off between the mandated reporter and Child Protective Services and the ongoing collaboration. So I want to talk a little bit about the handoff. And physician education, as you probably know, related to child abuse, really has focused heavily on reporting. When in doubt, report. But we really don't focus on how to report, or perhaps more importantly, what our responsibility is after we report. So as physicians, we do spend a lot of time ensuring quality of handoffs. These are just a couple of papers, but there's an entire literature on what we should do in order to provide quality handoffs and improve patient safety. So we know it, but somehow when we hand off to Child Protective Services, we don't use what we know in medicine. So here's just a couple of characteristics of a good handoff. The first is it's synchronous, which is very important, either face-to-face or by telephone, so that there's the ability to speak with each other and not simply give information. So although reporting to Child Protective Services electronically or having one of our social workers call in the report is good for workflow, it's really not good for handing off information because there's no back and forth. Good handoffs are standardized, as we always talk about our sign-outs, the residents sign out. When you leave your residency program, you sign out your patients. We do it in a very standardized way. Immediate access to raw data has also been shown to be important for an accurate, good handoff. But also importantly, you need in a good handoff both facts and clinical decision-making. And this usually includes an assessment of your diagnostic uncertainty. When you sign out a patient, you say, this is definitely an asthmatic, or we're not really sure whether this child is wheezing because there's a foreign body, or it's a new onset asthma, or it's an RSV. So we usually include those things in our sign-off. But here are a couple of reports to Child Protective Services from our own colleagues. Child comes in with a femur fracture. Fell off bed, skeletal survey had CT negative, believe this is accidental. 9-month-old bruising to arms, parents say they were holding his arms while he was standing, skeletal survey negative. These are the actual reports. I put the age in parentheses because it wasn't part of the report. There was nothing else provided to Child Protective Services. And each of these cases, probably not surprisingly, was screened out. In fact, the second one says this is accidental. And each of these children came back with a life-threatening abusive injury, which really is just, I think, shows us that if you don't provide information, there is no way that Child Protective Services will know what to do. So I just want to make a comment about screening out, which is something which mandated reporters often don't understand. Child Protective Services is not like the police. The police have to respond to things and they have the capacity to respond to everything that they need to respond to. Child Protective Services is not funded to do that. They have the ability to respond to approximately half of the cases that are called into Child Protective Services. They simply do not have the capacity to respond to every call. So they have to make decisions with every single call about whether they should take this call or whether they should simply screen it out. And so, as I mentioned before, if you report something and say this is accidental, there is no reason Child Protective Services would even have the ability to get involved because you're not saying you have a reasonable suspicion of abuse or neglect. So this screening out is really, really important because once that happens, there's basically the case is not being evaluated anymore and the child will now not be part of the system. So how do you work with Child Protective Services as a colleague? The first thing is when you report, provide clear information which tells them what they need to know and how they know whether to protect a child, and do it the same way you do with your colleagues in a standardized way with facts and clinical assessments. Really, why are you consulting them? What are the injuries? If it's medical neglect, what are the medical issues? How worried are you? Is this definitely abuse or are you just concerned about abuse? And then what you want them to do once they get the report. And I'm going to show you some cases where this becomes very critical. Do you want them to call EMS, bring the child to the ED, or make an outpatient appointment? And perhaps most importantly, as we're going to talk about, give them a way to contact you, a cell or a backline, not the children's hospital operator. And when they return your page, which is following up on your report, which they are required by law to do, unless it's screened out, talk with them and have a conversation. This is your synchronous handoff because, as I mentioned, most of our child lines or child abuse reports are made by a social worker or made electronically. So it really isn't a synchronous handoff. And it's also going to be with a state, someone at the state, whereas this, when they call you back, it's going to be the person at our county who is working on this report. Recognize that Child Protective Services can't do everything you might want. Parents have a lot of rights and there are lots of rules and regulations that Child Protective Services needs to follow. Please respect that they have more information than you do and that they are using this information to make decisions. Understand that they have almost no medical knowledge, and if they don't know what you're saying, they're going to use Dr. Google to try to figure it out. But also understand that they have a hierarchy like we do. The first person that calls you is their caseworker. That's kind of like our intern. Their supervisors are more like our senior residents. Their clinical leaders may be like our fellows, and the attendings, maybe one of their clinical leaders or maybe their regional office director. So this is important to understand because if you talk with we would say their intern, their caseworker, and you don't think that the information is being properly handed off or they're not understanding what the issues are, you can go up the hierarchy just like somebody would do here. If they don't think the intern understands, they may call the resident or the fellow or even the attending if they feel like they need somebody else to talk with. We know that when physicians and Child Protective Services work together, outcomes are better. These are just two papers from the University of Texas and from Connecticut looking at this. And these two papers together evaluated about 400 reports made to Child Protective Services. They used the child abuse pediatrician as the expert, but it really was an expert insofar as they had communication and ongoing communication with Child Protective Services rather than simply just reporting. What was interesting is the referring physician, as we mentioned before, provides an assessment of the likelihood of abuse less than half the time in these 400 reports. So Child Protective Services, after reading the report, had no idea whether the person who was reporting was actually concerned. There were significant differences in opinion about the likelihood of abuse between the child abuse pediatrician and other physicians. And interesting, most commonly, the non-child abuse physician thought that it was abuse, but the child abuse physician who knew much more thought it was not. And they thought this difference was really some expertise, but actually just as importantly, continued information exchange and collaboration. So that shows that as you continue to talk and exchange information, the opinion about whether this child is at risk may change. Almost 30% of the time when the child abuse pediatrician said it was not abuse, Child Protective Services had already removed the child from the home because of the initial statement. So this has real effects on children. Many states have actually tried to enhance the Child Protective Services medical collaboration. Here's a few of the states. Pennsylvania, as you note, is not on this list. As part of the fellowship with Casey Family Programs, myself, my colleague from Philadelphia, Cindy Christian, and Kathy Palm, who's the head of the Center for Children's Justice in Pennsylvania, worked on a research brief, and it was called Public Laws and Investments Intended to Promote the Use of Medical Expertise in the Diagnosis and Treatment of Child Abuse and Neglect. And we went through every state that has these different collaborations, and we looked at the states and what they did, how these programs worked, and then tried to summarize what were the most important attributes of this kind of collaboration program to improve child outcomes. As I mentioned, Pennsylvania does not have a program, but we do have what's considered model legislation for collaboration between Child Protective Services and medical professionals. As you know, HIPAA has always excluded child abuse, but in practice, that hasn't often helped, as I'm going to talk about as well. So I'm sure most of you remember this. This was 2011, and Sandusky was arrested in November. And interestingly, for about 4 years before that, we had been trying to get the Pennsylvania legislature to put together a task force to address some of the very issues of collaboration, communication, that ultimately, as soon as Sandusky was arrested, within a month, we had this task force that we had been trying to get. So I served on this task force, which lasted for a year. We spoke with hundreds of people around the state, and a year later, we produced this report and made multiple recommendations to the legislature. So I want to focus on what I think is one of the most important achievements, and there were many important achievements, I think, from this task force, but it's Senate Bill 27, which both allows and requires collaboration between medical professionals and child protective services. So what this bill allows is that in cases which negatively affect the medical health of a child, so really anything where Child Protective Services is getting involved, a certified medical practitioner shall provide the county agency with the following information. Here's all the things that you need to tell Child Protective Services. Parental consent is not required, and you do not need to be the mandated reporter. You only need to be involved in the care of the child. So if, for example, an outside emergency room files a report and you are the PCP or you're the cardiologist taking care of the child, and Child Protective Services calls and says, I am conducting an active investigation, can you help provide me this information? You are required to provide it. And it also goes both ways. The county agency, Child Protective Services, needs to provide you with information. So if the report of child abuse is indicated, they need to tell you that. But they don't need to tell you that if you were not, if it's not indicated and you weren't the reporting source. But if you reported it, they do need to tell you, even if they didn't call it child abuse. They need to tell you if they accepted the child for services. And they need to provide you with the identity of other medical practitioners who are providing care. This becomes particularly important in medical child abuse cases where we're trying to figure out who are all the other providers that this child might be seeking care from, particularly if they're not in our system. So we have this Senate Bill 27 in Pennsylvania that I think really promotes this collaboration. And then we happen to live in a county, Allegheny County, which is really a leader in novel approaches to collaboration between Child Protective Services and medical professionals. And I'm going to talk about 3 of these. So the first is the Allegheny County Family Screening Score. And this is a predictive risk model, and it's used when a child is referred to our protective services for general protective services. And in Pennsylvania, we have 2 types of referrals. One is called Child Protective Services, and those are things like physical abuse. The vast majority of what's reported to Child Protective Services is considered general protective services and involves issues like anything related to neglect. So you cannot screen out a case, which is a Child Protective Services. They can only screen out cases potentially, which is general protective services. So the goal of the Allegheny Family Screening Score was to determine which general protective services could most safely be screened out and which they should not screen out. So it was built from hundreds of structured fields that are captured in our county's health service records. We have a very unique system where all of our jail data, our Department of Human Service data, our Child Protective Services data, our Medicaid data are all, well, not all Medicaid, are all linked in a single data system. There's a score, this AFST is a score of 1 to 20. The The higher your score, the higher your risk of being placed in foster care within 2 years. So it's a normally distributed score. So 5% of children have a score of 19 or 20, which is the highest risk. And with that, there's about a 40% chance that that child will end up in foster care by 2 years of age. I don't know if some of you saw this, but back in 2018, this AFST was the subject of a New York Times Magazine article. And recently, we validated this model using healthcare data, which I think is a research example of collaboration between Child Protective Services and our medical group. So our objective was to determine if this score, which we know predicts foster care placement, is also associated with hospital injury data. So we looked at over 47,000 kids referred to Allegheny Child Protective Services for any type of maltreatment tool. And then we looked at the ED hospitalizations in the period before, many, many years before that. And what we saw is the highest children with the highest scores, so our 19 or 20, had significantly higher rates of any cause injury and abusive injury. And you'll also see actually between these two or higher scores compared to children with the lowest 50%. So if your score was 10 or below on this score, you had a much lower rate of injury, either due to abuse or due to accidents. And if you notice, the kind of control was cancer. There shouldn't be any difference in the cancer rate between these two groups, which there isn't. So really this shows that this score classifies as high risk for placement in foster care, also shows that there's an increased risk of both ED and inpatient hospitalizations for injuries. So it was a way to really validate this with medical data. So I want to move on to the CHECS program, which is another really important example of collaboration. This program was developed in 2015 as a collaboration between our Child Advocacy Center and Allegheny County Child Protective Services. And it was to provide comprehensive healthcare assessment and care coordination for children and child welfare. So we have children's hospital nurses who are embedded in the Child Protective Services office. And that's true collaboration. They are literally work for children's, but they are sitting in our Child Protective Services office. This started with 3 nurses and 0.15 of our FTE time. We are now about to add our 7th nurse, and we have 0.4 of our physician time. And Dr. Wolford is our medical director of this program. And the number of children that have been evaluated by CHECS nurses in Allegheny County has gone up, as you can see, dramatically since we started. In 2019, over 7,718 kids were touched by a CHECS nurse. But what's so striking is during the same year, our Child Protective Services got almost 17,000 referrals. So that means less than 50% are being touched by CHECS. And this year, as you'll see, the projection is to be about 8,400 based on the data from through October. So really what became clear over time is these numbers are just so incredibly large. We can't touch all the children. And how can we better focus on the highest risk kids among this already group of really high risk kids? And that's where we came to this project that I started working on during my sabbatical, which is called Project Magico, which stands for Medical Assessment Guidelines to Improve Child Outcomes. So what is this? This is a program which focuses on medical and Child Protective Services collaboration for the subset of children at highest risk for fatalities and near fatalities. And our goal was to ensure rapid and accurate medical assessment of injuries, and also to ensure that children were being seen by a PCP, hoping that that PCP could become the safety net once Child Protective Services closed their case. We hypothesized that this program would decrease re-referrals, children that come into the system, the case is closed, they come back into the system, improve overall health, whether they were up to date on their well child care, whether they were being immunized, et cetera, and decrease the number of near fatalities or fatalities that we reviewed as a county where there had been prior missed opportunities, which were medically focused. So we chose children less than 3 because, as you remember by that graph about fatalities, that's the highest risk by far group for fatalities. And we chose specific allegations. So when you call a report into Child Protective Services, it is given an allegation. If you say the child hasn't been to their cardiology appointment and if they don't have surgery, they're going to have long-term effects. That's an allegation of medical neglect. So every single report has either one or more allegations. And we chose the allegations which had been most commonly identified in fatalities and near fatalities as missed opportunities to intervene. This is the list of allegations we chose. You can see most of them are physical abuse. And there's so many different allegations: causing bodily injury through recent act of beating, causing punching, scratching, pushing. All these different things are types of physical abuse and a type of allegation. Per se acts are a physical abuse where you don't have to have an injury. So if you interfere with the breathing of a child, that's a per se act, even if the child is fine. If you slap a child under one, that's a per se act. Inappropriate discipline, really obviously in an infant, there shouldn't be any discipline, but we still get many referrals for inappropriate discipline in young children. And then we put delay in seeking medical care because we had seen that many times when there was a report for inappropriate medical care or inadequate physical care, the concern by the reporting source was medical neglect, for example, delay in seeking care for a fracture. But what really should have been the concern is why the child had the fracture. So that's why we put, even though our focus was on violence, we wanted to put some things in that were related to medical care. So what happens in this program? So every day, the data system at the Child Protective Services develops a list of children who are eligible for this Project Magico. Eligible children get divided based on the office they're assigned to. So we have 5 regional offices in Allegheny County, and children are basically based on where they live. They are basically evaluated and receive services from that office. The exception is intake, where many of the children come into first before they get distributed. So our case group really was those who came into the intake office or the East Regional Office. Those happened to be co-located, which was one of the reasons, because it was easy to train because all the caseworkers are right there. And then if you had a Central Regional Office, Mon Valley, North Regional, or South Regional Office, you were essentially our control group. And initially we thought about this as a randomized controlled trial, and we were going to look at the differences in outcome between the cases and the controlled. But over time, it became really clear there was a lot of movement between offices. And so it was probably the least clean RCT you could ever have because there was just so much movement between them. But as time went on, it became less about the science and more about logistics as well. Because in order to change practice, to educate, to get buy-in, there was so much work that needed to get done with the caseworkers that we really couldn't have taken on more than just those 2 initial offices. So what happens? The caseworkers get assigned to the case and they follow an algorithm, which I'm going to show you, to determine what they need to do. There took a lot of education, buy-in, communication, a lot of training, and a lot of feedback from the caseworkers about what they thought would work and wouldn't work. Then each of the cases every day get reviewed by myself and the checks nurse. There's a checks nurse that is assigned to each of these offices. I look at what's the acute allegation. Does the child need a medical evaluation, and by whom, and when do they need it? The checks nurse looks at the child's health. Is the child up to date with well child care? What are the unmet needs? Do they have subspecialty appointments they need to make? And then we always look at the family health needs. Are there other siblings with needs? Because what we found is often Child Protective Services would get a referral on one child, then 3 months later, they would get one on the other child in the home who had not been evaluated at the time that first child was evaluated for whatever reason. So this is one of the algorithms we had. We divided our algorithms, there's 2 of them. If the initial evaluation is not done by a medical professional, so example, a police officer calls in a report or an anonymous reporting source, and they are alleging one of these allegations. The caseworker follows this during the home visit. They are looking, they say, is the child in pain? If they're less than 1, do they have any bruise, any burn, any bite, any of these things? Or if you're under 3, does the child have any injuries in these high-risk areas, the torso, the ear, the neck? And if it was a per se act, did it occur less than 5 days ago? And based on that, they need to decide what to do. Of course, and I'm going to talk more about this, COVID started during the middle of this project. And of course, the idea of bringing a child to a PCP when the PCPs were closed required almost a complete change. So we actually have a completely separate algorithm that occurred during March. We actually stopped it when things got better, and we will probably have to reinitiate the COVID algorithm as things get worse again. And part of this, I should go back, as you can notice, that prior to, one of the things we asked people to do was bring the child to the PCP. And prior to that PCP visit, to complete this medical communication form, and some of you in the primary care center and other places may recognize this. The goal of this form was to get Child Protective Services, the parent, and the PCP to start talking about what the concerns were. So the parent actually fills out the top of the form. There's actually lines here. I just condensed it so you could see the questions. And you say to the parents, what are your concerns? Why are you bringing your child to the doctor? And then the Child Protective Services says, what would you like the doctor to address? And then the caseworker writes their name, their phone number, the supervisor's name, and the supervisor's phone number. It was fascinating to see what the parents were concerned about versus what the Child Protective Services person was concerned about. And then the medical provider documents information, both about the physical exam, weight and height, development, well child care, immunizations, and follow-up. And then this was either went back with the parent or got back to the PCP, back to the Child Protective Services office. And then we had, this is the second algorithm, if they have already been evaluated by a medical professional. And these are a little bit easier. This means, like, for example, AGH sees a child and reports it for child protective for abuse. We just need to figure out how to get that information. So of course, the best laid plans. Our project period was October 1st, 2019. We ended in July of 2020. And of course, just about halfway through there is when COVID started. And this was really when the caseworkers were finally getting used to the algorithm. The first couple of months were really just, you have a lot of caseworkers, they're learning how to use this, how to do this in everyday practice. And of course, we had the issue of if PCP is closed, you can't bring the children. There's also, as you might have seen in the lay press, there was a marked decrease in Child Protective Services referrals at the start of the pandemic. We saw almost no medical neglect for a few months because nobody was going to any physicians. And as you might expect, we've now seen this increase, a tremendous increase afterwards. And of course, Child Protective Services was not able to see some families in person, so they couldn't assess whether the child had injuries. And some of them would be asking parents to take clothes off on a video. It was just very, very difficult to actually do this. But given all that, what did we find? There were 586 referrals, which met these criteria during that 9.5 months. So there are about 5,000 referrals annually in kids less than 3. So basically these referrals were about 15% of the referrals in this age group. So even though 586 is a lot of referrals for these highest risk kids, it's actually not that large. It's only a small percent of all the referrals they were getting in this group. The average age was 16 months, about half were female, about 40% were white, 40% were Black, 15% were multiracial. Over half of these referrals were made by medical professionals, and it might be significantly higher because if a social worker makes the call, the state calls that a social worker referral. I did try to go back by hand and look at the actual place that reported it to determine how many of those social work reports were actually medical professionals, but it's very dirty and hard to do. But at least half of these referrals are these highest risk referrals are made by medical professionals. 92% of the kids were referred only once during the 9.5 months, but 8% had more than one referral with these high-risk allegations during that 9 months. What I was struck by was the fact that 20% of these kids already had an open case at the time this referral came in. And this is actually almost identical to the rate of all children less than 3. I think I was just struck that means 1 out of 5 children I'm reporting has already been reported and has somebody already working with the family. And in my mind, that means whatever's being done with the family may not be working. And of these 586 kids, there had been a total of 576 referrals in the prior 1.5 years before. So this just shows how many, that this is really just a lot of kids are rotating through Child Protective Services multiple times. So what were they coming in for? The number of allegations range from 1 to 11. So you can have multiple allegations on one child. The most common were domestic violence. So generally it's domestic violence if the parents are fighting, but the child is not in the actual fight and does not get injured. 18% were for medical neglect, 13% were for inappropriate discipline. A quarter of these were what we consider the Child Protective Services, and those are the causing bodily injury. So the child has an injury. And then 5% had a combination of those. So what happened? About 1/3 of these cases were screened out, which is lower than the 38%. So it was 29% screened out, lower than 38% in this age group. So that's encouraging, although it's still striking that 29% of these very high risk allegations were screened out. 40% of the ones that were remaining were ultimately accepted for service. What's striking again is that 47% of those were connected to cases which were already opened. So they were already getting services, and now they're getting more services. This is significantly higher than the overall acceptance rate in Child Protective Services, which is about 25%. So that's encouraging that more children were accepted for services, but discouraging that many of these families were already getting services, and yet they had another referral which required more services. I think the other thing that was really striking was the AFST scores. So as I said to you, this should be a normal distribution where the peak is at 10, but here we've got this huge right shift, so that many of these children had scores in the 15, 16, 17 range. So these were high risk children, which is really what we anticipated. So what did I learn from all this? I think there were a couple general lessons. The first is wow and wow. The level of violence in these children's lives was almost unbelievable. I had never been on the Child Protective Services side insofar as I saw the referrals that we made and only the ones that we made. But once I was in the database in Child Protective Services, I was seeing the referrals as they came in from the police, from anonymous people, from all these different sources. And the level of violence was really, truly overwhelming. The number of risks these children had, I said, it was almost unbelievable. So somebody would come into the home and there'd be a gun on the table and the parents would be fighting. And there was drugs found in the corner and the child was unclothed. And so the police came and brought the child, right? But all we see is the child gets brought in by the police. And we don't know all of those other things that were present in the environment of that child. As I said, I saw the same children coming back and the siblings of the same children coming back. And I think I realized that I had been very naive to think that with this program, we could change a trajectory with this relatively small intervention. And I began to really understand what the day-to-day life is at Child Protective Services. And I was just thinking about, what's a good way to compare it to? And I thought it's like flying an airplane when you're trying to make the repairs. And as you're trying to do all that, you see another airplane coming straight at you. And every day I said, I think the Child Advocacy Center, that we live in chaos sometimes, but I had never seen anything like this. And it made me realize how incredibly difficult research was in this population. But the specific lessons I learned, there's an incredible amount of time being spent by Child Protective Services trying to make contact with the family. The number of inaccurate phone numbers and inaccurate addresses on the child abuse reports was unbelievable. And I think all of us can understand when we make reports, we copy the address and the phone number that are sitting in Cerner or potentially sitting in Epic, which actually might not be the same. And we might pick the wrong one and those might not have been updated. And this wasn't just for ones from medical professionals, but the number of inaccurate ones. So we saw Child Protective Services workers sometimes going 2, 3, 4 places to try to find a family that of course didn't want to be found either. So once they finally did get the right address, sometimes they weren't let in anyway. So much time was spent trying to reach mandated reporters. I can't tell you how many attempts to reach people were documented by the Child Protective Services workers. So it really said a direct phone number to reach the mandated reporter would immeasurably improve child safety. But once I stopped looking at this enormity of it and how difficult it was going to be to make these big changes, I started focusing on the individual children. I'm going to give you a couple of examples. This is a 10-month-old subspecialty patient. Obviously, I've changed some of the details here, who came to clinic at Children's and needed to be admitted due to repeated hypoglycemia, which potentially was life-threatening. The family could not do a direct admission because there were multiple other children there. And obviously during COVID, we never really have other children, but you couldn't even go to the sibling center. So the mother agreed to bring that 10-month-old the next day. But then the next day she didn't show up. So the treating team called her and she said, I don't have a ride. I can't come till the following day. Well, they were very uncomfortable with that because they really had not wanted to let her go home the prior day. So the APP filed a child line. So I can tell you what would have happened before Project Magico is the caseworker would try to reach out. They would call the social worker who reported it, but that person might not be there. Then they'd call the children's operator, and then they'd get the administrative assistant who works in the division where that Dr. APP is, and then that person would leave a message for them. And after a few hours, the caseworker just had to go out to the home. So they would go to the home and see the child who probably looked entirely well, presuming they weren't hypoglycemic at the time. The family says they weren't told it was an emergency and they're going the next day. They already have a ride. So the caseworker leaves. The mandated reporter is now really upset that Child Protective Services did nothing and the at-risk child is still sitting in their house. So what actually happened, this was one of the kids in Project Magico. It came up on our daily list. I reviewed the child line report and I talked with the caseworker. The caseworker had already talked with the mother who said, I'll let you come to my house at 12:30. So the first thing the caseworker said to me is that okay? Like, is 3 hours too long? Can I wait that long? I said, yes, you can wait 3 hours because we've already waited 18. So I paged the PA directly and the PA obviously called me right back. And I said, what do you want Child Protective Services to do when they get to this house? I said, do you want them to bring him to the ED? What do you want them to do? And we decided on a direct admission. And the PA, of course, gave me her cell phone number. So Child Protective Services went to the home and the father refused to bring the child. He became very violent and erratic. So then the caseworker had to call the police and then the police showed up. And after several hours, the child did come to Children's. Just gives you a little view into, it's not that easy when the caseworkers go out to the home and try to intervene. In this case, the caseworker was actually able to they got a court order to get this child. If it's something that wasn't this severe, they might not have been able to get that court order. And they might not have had a choice. They may have had to make the decision, do I try to get a court order? Do I call the physician and try to decide how important this was? But in this case, they knew how important this was. So they were able to get a judge to allow them to do this. Child came to Children's, was admitted, and the caseworker and the treating team had ongoing conversations throughout the hospitalization. This is really the way it should be and how smoothly it should go. And so we thought this was one of our successes. Here's another case, a 7-month-old seen in a non-UPMC ED, reported for bruising after a fall from a high chair. It was a Child Protective Services investigation, but the report didn't say whether they were worried about abuse or whether they had done a skeletal survey or anything else. So we were really stuck. We had a 7-month-old with bruising. Came up on our list, and the caseworker called and they told me, I've already called the emergency department and they won't even tell me whether the patient had been there and they won't give me any information, but they reported it. They told Child Protective Services they needed consent. So I called the emergency room and said, maybe I can help you. Of course, I was put through right away. And actually the person who picked up the phone happened to be a doc who had taken an Act 31 child abuse training I had given. They said, oh, I know who you are. They looked through the record. They gave me the information. Child had not gotten a skeletal survey, and we had the child at the Child Advocacy Center with the sibling that afternoon for evaluation. And our last example is a domestic dispute. Somebody at the scene reported the baby had a mark on the face. Unclear if it was even related to the event. Caseworker went to the home, infant wasn't there, went to another address, not there, finally found the infant at the 3rd place and noticed a little scratch. So they looked at the algorithm and said, ooh, this is a 3-month-old, and they brought the infant to our ED, and this child had multiple injuries. So I think when we talk about collaboration, it goes both ways, of course. So I said it as I prepared for this talk, I reached out to some of my colleagues at Child Protective Services and said, what did you think about this program? And here were a couple of the quotes. I just want to talk about 2 of them. The first one is, Project Magico has elevated concerns that might previously been overlooked due to caseload and time constraints. And I really think that's an important one because we have to recognize that Child Protective Service is constantly figuring out which cases are most important. And this was clear to them. If you were a Project Magico child, this went to the top of your barrel. It also allowed for enhanced oversight. There is a lot of supervision that goes on in Child Protective Services, and the clinical managers and supervisors, so really like our fellows and our attendings, chose the Project Magico cases for routine supervision to make sure that these kids were not falling through the cracks. So what's next for Project Magico? Obviously we're done with our study period. And I think everybody at Child Protective Services, and I myself included, feel that this program really did improve our ability to intervene quickly in this very high-risk group. So I'm very happy to say that starting 2 weeks ago, we have a new physician at the Child Advocacy Center, Dr. Sehud, who has been in private practice for almost 20 years and is coming back as a new child advocacy attending. And her role is being funded in part by Child Protective Services in Allegheny County. And she is essentially going to be their pediatrician. And her role is going to be to try to improve, kind of expand on the Project Magico so that we can have it in different offices, but also specifically try to improve the relationships with our primary care providers and improve some of these handoffs, improve some of this communication. So I said, Dr. Sehud just started, but we're very happy that this will be a role for her as we move forward. So in conclusion, I said the number of children who die from maltreatment is obviously a national crisis. Making a report to Child Protective Services when you have concerns about a child is the first step, but your job cannot end there. It is just the start of what your role is as a mandated reporter. Child Protective Services workers are our colleagues, they are our partners, and we are all trying to do the same thing. We want to protect children, and ideally, we want to change the trajectory of their lives. So please treat our Child Protective Services workers as you would your colleagues. The laws protect your ability to talk with Child Protective Services when they are investigating, even if you didn't report it. I said I continue to have been struck throughout this the Project Magico period was how often physicians absolutely refuse. And it wasn't, I was like, it's not always physicians. It's often front office staff so that the calls are not even getting to the physicians, but they will not talk to Child Protective Services. They're asking for forms, and when the forms get sent, they reject the forms. So they're putting up so many barriers to this collaboration that really shouldn't be there because our laws allow this collaboration to occur. There are a lot of things you can do to improve the ability of Child Protective Services to respond. I said, be clear and precise in your concerns, reasonable in your expectations. Please give Child Protective Services a cell phone number of a back line or something else to help them get in touch with you. Confirm the family's address and phone number. This is obviously an issue in everything that we do, whether it's, calling a family back to the emergency room after a positive, blood culture. But here it was just striking, I think, that how often the address was simply not correct. And Child Protective Services has no way to know where to go if we don't tell them. Reach out to Child Protective Services if you don't hear back after you make a report. Talk with the intake person, talk with the supervisor, and try to put yourself in their shoes. And I think most importantly, remember all the supports I just talked about are in our county, but many of the children that we care for are from counties which have none of what our county has. They don't have nurses embedded in their offices. They don't have physician support that our county has. So you have to spend even more time with those counties because they don't have all the resources. So that's it. I wanted to leave a couple of minutes for questions. I'm going to stop sharing my screen.
All right. Thank you so much, Dr. Berger, for that incredible presentation. I wanted to let you and all our participants know that we had over 200 participants today for Grand Rounds, which was a new milestone and a record for CHP Grand Rounds to our knowledge. And so that's absolutely fantastic and really speaks to the importance and our collective action in this space. And so there were several questions in the Q&A, and that they were coming on throughout the presentation. I'll try to go through them. The first one was from Dr. Gaines. Just wanted to clarify at the beginning of the presentation when you were mentioning the federal act in 2013, if there's any federal funding attached to that.
For the Commission to Eliminate Child Abuse and Neglect Fatalities. So actually, yes, Pat Toomey was one of the sponsors of this, and actually he held it up until the federal government provided funding for this, but the funding was not actually for the intervention. The funding was for the commission to do its work. So that has actually been one of the, barriers would be an understatement. Essentially, nothing has happened to this report since the start of the current administration. There has been some work by Casey Family Programs and others to try to implement some of it, but I think that there will be a significant opportunity starting in January. And I think many of the people involved in this commission are hoping that we can move forward some of these recommendations in the new administration.
Dr. Justin Yu of Supportive Care asked, I worry about including, in quotes, my level of worry. If we assess situations as low risks, are we liable if cases are screened out? Also, does this incentivize labeling each case as high risk?
So in terms of low risk, I think what our role is to describe from our medical perspective how likely something is to be abuse. So by low risk, we say, I'm concerned this reaches reasonable suspicion, but certainly not definitive. Or we often will say in our reports, we need more information. So as a mandated reporter, they say you should report if you have reasonable concerns. Reasonable concerns is a low bar. And if I have a low bar being that's the least concern you would be to report. But Child Protective Services, again, has to figure out which are the ones they need to do something immediately. So I think it's important to give your level of concern because they would have no way to know, for example, that a child with a metaphyseal fracture is almost diagnostic of abuse, but a child with a, clavicle fracture who's 4 months old, it's concerning, but they don't need to run and remove that child from the home. So they don't have any way to assess the medical risk. Whether the child has a high AFST score, this is overall risk is really something that they're going to assess. But from the medical side, we have to provide them with the medical assessment of that medical possibility of maltreatment. So I don't think there's any liability issue. This is our expertise and sharing it with them.
Dr. Vubos asks, in the Project Magico, in the medical communication form, what were parents' typical answers as to their concerns, reasons for bringing their child to the doctor?
So I'll give you a couple. That's a really interesting. I didn't have time to go through that, but part of the problem is the communication form, needless to say, once COVID started, it was much harder to use. But prior to that, we had a couple statements. For example, one parent says, Child Protective Services is worried that my child is hurt just because I turned my head for a few minutes to go get a smoke. And so the child had, I think, apparently fallen out of a bed and had a whole bunch of injuries. And their perception was, I turned my head for a second and now they're worried I abused my child. So, and I said, we had another one, for example, when they said, I'm really worried that somebody is smoking marijuana in front of my child. That wasn't the concern that had been called in. That wasn't why the child was being brought in, but the parent had a concern about someone smoking marijuana. So it just brought out it just shows you how the parents' concerns are not always the same as the Child Protective Services concerns. And I think that's important, because if we're not communicating to the parents about what they are concerned about, the entire relationship with Child Protective Services doesn't really work.
Absolutely. Dr. Arslanian asks, how did the US rates of child maltreatment, abuse, neglect compare with Scandinavian countries or the EU, if you happen to know?
So it's always very hard to compare with other countries because the laws are so different. However, when you look at objective measures, for example, how many infants are taken to an operating room with a subdural hemorrhage in Japan versus the EU versus Scandinavian countries versus the United States, it actually becomes a little easier to make those comparisons. And the rates of abuse in the Scandinavian countries in particular appear to be significantly lower. And one of the reasons is probably, and people have done some research on this, that all parents get a 1-year maternity paternity leave when they have a child. If they have twins, they get 2 years. The government supports you. There's universal daycare. So many of the safety nets that the United States does not have, Scandinavian countries have. Japan is probably one of the most interesting countries where many years ago, there were almost very, very low cases of, for example, I said subdurals. And I heard a talk by a neurosurgeon who said when he was a resident and fellow, he did 0 surgeries for subdurals on infants. And then as he progressed in his career, and we had 2 parents working, children in daycare, very similar structure to the United States, all of a sudden, he was going to the operating room to at least once a month with subdurals. So it shows also that as cultures change, rates of abuse can change.
We have another question. Can caseworkers have a handout they can provide when someone gives them pushback? I'm new to Pennsylvania and first encountered a CHP nurse from the office a couple months ago, and she kindly explained to me what her role was.
Oh, you mean a checks nurse?
Yes. Mm-hmm.
So, I said, we certainly can provide more information. I thought you were getting at we have a form that Child Protective Services actually provides to families that explains why they might need a skeletal survey or why they might need a head CT. So that's actually something we developed. It's actually in our ER as well that they use, but certainly we can provide more information about what the checks nurses do, but really their role is to be a liaison between the families and our physicians. So you may see them at the appointments at Children's, and you may see them calling to get appointments, things like that. But certainly, yes, to reach out to us or Dr. Wolford, and we can provide more information.
Dr. Suresh asks, thanks, Rachel. The variance in reporting / data collection across all counties in PA, with all the efforts that you mentioned, how much has it really improved?
The data collection has not improved. So the data collection is a huge issue. Interestingly, as I alluded to that report that we made, that Dr. Christian and Kathy Palm and myself, that was actually a 2-pronged project that was funded by Casey Family Programs. And the other one was to actually compare rates of completed medical evaluations in children in all the counties under the age of 1 referred in with a fracture. So very specific. And we were trying to link the Child Protective Services data to the Medicaid data. And it turns out that every single county houses their own data, and none of it is actually put into a huge database of any of this specific information. So our data is just atrocious, and it's an issue that many states have. Our county is incredibly lucky. Our data is very robust. But even putting some of this together, it's robust, but it's still difficult to use. But we, again, are a unique county in that way.
On a similar question, and I believe it's from Dr. Liz Miller, she says, that was amazing, Rachel. What can we do within our healthcare system to facilitate these vital collaborations with CPS? Any electronic health record strategies, more training for our clinical staff, and how might these collaborations help address systemic racism?
So those are all really good questions. I guess I go one at a time. I'll go backwards because I remember the last one first. The systemic racism issue is something which has been a separate, almost I say, initiative that we have been working on with Allegheny County, and actually has been a big push of our work in the electronic health record. And that's actually always been, from the very beginning, it was funded as on an RFP to decrease racial disparities. So we have been working very hard on these issues, because if we do things the same for every patient, we are likely to see some of these decreases as a secondary benefit of consistency. I think, I'm sorry, I already forgot what the other two questions were. What was the other question?
The other questions were on just electronic health record strategies and any training of clinical staff, and how might these collaborations help address systemic racism?
Okay, so in terms of training of clinical staff, I mean, we try. I think the problem is there's so much turnover on the Child Protective Services side. There's a lot of turnover on our side. And I think some of the things we see are much broader than child protection. Issues of taking down correct phone numbers, to rep zip codes, willing to talk to people in Child Protective Services. Some of these are much broader than us. And so I absolutely agree, Liz, with all those things. And these are just really big things to fix. But I absolutely 100% agree.
Excellent. And so this concludes our time right now for Grand Rounds. However, this is a fascinating discussion, and we can continue to ask additional questions in the meet and greet session with Dr. Berger, as well as facilitated by our Vice Chair of Education, Dr. Noel Zuckerbraun, right now between 9 and 9:30. So I encourage as many of you to click on the link that's in the chat that Colleen has posted, and we can continue that discussion and that additional Zoom. So thank you all so much again for CHP Grand Rounds. See you next week.